I request Dr. Bhavna to start her first talk, Orbital Inflammatory Diseases, a Pandora's Box.
Good afternoon, everybody. I'll be presenting an overview of the orbital inflammatory disorders. So orbital inflammatory disorders are all disorders that affect some or all of the structures contained within the orbit external to the ocular globe, may extend beyond the orbit into the cavernous sinus through the orbital apex, and importantly need to be differentiated from neoplastic and infectious diseases that may have a similar presentation. Brief classification: idiopathic inflammatory diseases, neoplastic, congenital malformations, infectious, and systemic inflammatory diseases. Most common clinical features could be pain, which is a prominent complaint. If involvement of extraocular muscles, there can be diplopia. Lacrimal gland involvement can lead to a painful supralateral orbital swelling. Generalized orbital tissue involvement can lead to proptosis, chemosis, periorbital swelling, and even blindness in severe cases due to optic nerve compression. The onset can be acute to insidious or subacute. Orbital congestion from a rapidly growing tumor may also mimic orbital cellulitis and tumor necrosis, and this may provoke an inflammatory reaction. Coming to some of the specific diseases, a brief overview of thyroid-associated ophthalmopathy, which is the most common cause of orbital inflammation in adults, accounting for nearly 60% of cases. Mean age of onset is around 40 years, more common in women, and smoking appears to be a significant factor for both increase and severity of the thyroid ophthalmopathy. The pathophysiology is autoimmune mediated process, with marked infiltration of lymphocytes and macrophages, which leads to a swelling of the extraocular muscles, which spares the tendinous insertion of the muscles. This is an important differentiation from the idiopathic orbital inflammation that shows even more extensive lymphocytic infiltration, so it includes the tendinous insertions also. Clinical features: thyroid ophthalmopathy presents with the typical clinical features, like in this patient, there is a lid lag or lagophthalmos, bilateral lid retraction. Diagnosis is with the help of a complete thyroid profile and MRI, being more sensitive for TAO than CT, where we see the characteristic enlargement of the extraocular muscles. They appear to have a characteristic spindle shape, as can be seen in this picture. For early cases of TAO with a small deviation, we can prescribe prisms. We have to manage the dry eye and the corneal exposure, if any. Depending on the classification and the UGOGO and the visa staging, we can start systemic steroids for severe inflammation and cases with compressive optic neuropathy. In severe cases, a combined therapy of steroid, radiation, and surgery may be considered. Immunotherapy in the form of rituximab, cyclosporin, octreotide, IVIG are relatively less common modality of treatment, but reserved for resistant cases. Orbital inflammatory disease or pseudotumor or IOID is the third most common orbital disease causing inflammation after Graves' orbitopathy and lymphoproliferative diseases. The common sites for IOID are the lacrimal glands, the extraocular muscles, perineuritis of the optic nerve, orbital cellulitis, orbital apicitis, also known as Tolosa-Hunt syndrome, periscleritis, or diffuse orbital inflammatory disease. Coming to a brief about dacryoadenitis, it presents as a painful firm erythematous mass in the lateral upper lid, and there may be proptosis also. There is a diffuse enlargement of the gland, which might include both the orbital and the palpebral lobe, along with inflammation of the surrounding tissues also. This is a picture of dacryoadenitis, where the T2 section shows diffuse enlargement of the left lacrimal gland. Myositis is a non-infectious inflammatory condition affecting the extraocular muscles, presenting with mostly unilateral orbital or periorbital pain, painful and restricted extraocular muscles, proptosis, edema, and hyperemia of the conjunctiva. Important differentials for myositis include TAO, IgG4-related disease, lymphoma, and carotid cavernous fistulas. This is a picture which is showing the involvement of the superior and medial rectors, the myositis. Cellulitis is inflammation of the preseptal or the postseptal fat. Patients typically present with proptosis, chemosis, and painful diplopia. Best evaluated on contrast-enhanced T1 MRI. Infectious cellulitis shares similar imaging features, so important to obtain any clinical history of fever, sinusitis, meningitis, as well as any blood picture of leukocytosis. So this is a picture showing a diffuse cellulitic orbital inflammatory response. Optic perineuritis is intraorbital inflammation that extends along the optic nerve and the nerve sheath. Because inflammation is affecting the nerve sheath rather than the nerve itself, then the primary presenting features are mostly pain, while vision, visual fields, and color visions are typically unaffected. So the important differentials for optic perineuritis are meningioma and demyelinating lesions. Meningioma can be differentiated on the basis of a CT scan. So this is a picture of a perineuritic orbital inflammatory disease, and this is how we differentiate from the meningioma of the right optic nerve sheath. Idiopathic orbital inflammation sometimes may present as a focal mass, as a focal inflammatory mass, and almost 9% of cases can present in that way. So it presents with eyelid edema, or if it is more extensive, they can be an optic nerve atrophy, to be differentiated from lymphomatous lesions, which present more commonly as a palpable mass. So this is an orbital inflammatory disease which is producing a focal mass effect. Orbital apicitis is involvement of the orbital apex. It is relatively less common and associated with poorer outcome because there's a risk of invading the optic nerve early and also the cavernous sinus. If it invades the cavernous sinus, it is known as an entity called Tolosa-Hunt syndrome, characterized by cavernous sinus inflammation, relapsing, remitting acute orbital pain, and paralysis of the cranial nerves, third, fourth, fifth, first branch, and the sixth nerve. Typical features of Tolosa-Hunt syndrome are diplopia, visual loss, paresthesias along the forehead, and a unilateral involvement. The criteria for Tolosa-Hunt syndrome diagnosis includes episodes of unilateral orbital pain for an average of 8 weeks, associated paresis of the cranial nerves, pain that is relieved within 72 hours of steroid therapy, and exclusion of any other similar conditions by neuroimaging and angiography. First line of treatment is corticosteroid, followed by immunosuppressive treatment in the form of methotrexate and azathioprine in the non-responsive cases. In spite of treatment, relapse has been seen in about 40% cases. So coming to a brief about IgG4 related diseases, it was first described in a patient with autoimmune pancreatitis who had high serum IgG4 levels. It is considered as a multisystem disorder which involves the pancreas, the biliary tree, the salivary glands, the kidney, lungs, skin, and prostate. So there's a multisystemic involvement. There could be a hypertrophic pachymeningitis and hypophysitis if the CNS involvement is there. In orbits, more commonly the lacrimal glands are involved, followed by the extraocular muscles, followed by the adipose tissue. Clinical features are a painless unilateral or sometimes bilateral periorbital swelling and erythema due to if the lacrimal gland involvement is there in the supralateral quadrant. Compressive optic neuropathy is relatively less common, and there might be an associated salivary gland enlargement. So diagnostic criteria is based on the imaging studies which show enlargement of the lacrimal gland or the extraocular muscles, or they could be a mass effect or enlargement or hypertrophic lesions in the various ophthalmic tissues. Confirmation is by a histopathological confirmation. Blood test is helpful in adding to the diagnosis where we see an elevated serum IgG4 level. First line of treatment is again corticosteroid, with which the relapse rate has been reported to be as high as 70%. Treatment of relapse involves 6 to 10 weeks of steroid or rituximab. Relapse can also be seen with rituximab after 6 months. Sarcoidosis is another cause of orbital inflammation. It is an idiopathic multisystem inflammatory disorder. Ophthalmic disease is seen in about 25 to 50% of patients, among which even anterior and posterior uveitis could be there. Sarcoid infiltration of orbit is relatively less common and present only in 25% of the cases with ocular involvement and in 10% of all total patients of sarcoidosis. Generally, orbital involvement in sarcoidosis is limited to the lacrimal glands. Presentation is similar as the idiopathic inflammatory disorders with pain, ophthalmoplegia, proptosis, and later in extensive cases there may be diminished vision. Symptoms characteristically tend to wax and wane, and there might be spontaneous remissions also. ACE levels are useful for the diagnosis, but it doesn't help if the pulmonary involvement is not there. The other sensitive investigation is chest CT scan. There might be orbital inflammation might be caused by vasculitis also in the form of a Churg-Strauss disease, polyarthritis nodosa, GCA, Wegener's granulomatosis. This has a special predilection for orbital tissue. An ophthalmic disease affects about 20 to 50% of patients at some point in the course of Wegener granulomatosis, and it might be the initial presentation in about 8 to 16% of cases. So this is a brief about the orbital inflammatory disorders and their typical radiological findings. A few rare causes of orbital inflammation are xanthogranulomatous disease, adult onset xanthogranuloma, Erdheim-Chester disease, Castleman's disease, Kimura's disease, and angiolymphoid hyperplasia with eosinophilia, Rosai-Dorfman disease, to name a few, and we need a biopsy and a histopathological diagnosis to confirm them. Thank you.
Thank you, Bhavna, for giving an overview about all the orbital inflammation.